Hi, I'm Andrea Watkinson, Executive Director of Cancer Services for Unity Point Health, St. Luke's Hospital, and the Nassif Community Cancer Center in Cedar Rapids, Iowa. As a leader in cancer screening and treatment in Iowa, we're proud to sponsor the Iowa Ideas In-Depth Week Cancer in Iowa series. As Iowa continues to see some of the highest cancer rates in the nation, it's more critical than ever to address the issues causing this trend and to educate our communities on the resources available in our state. This series will take an in-depth look at everything from cancer rates and causation to research and long-term impact cancer has on the state of Iowa. We'll also discuss advancements in treatment and how crucial it is to complete your cancer screenings regularly and on time. We hope you find these sessions informative and find valuable takeaways. Our overall goal at Unity Point Health, St. Luke's, and the Nassif Community Cancer Center is to reduce cancer rates and work towards a healthier state for all Iowans. Enjoy the event. Thank you.
Good afternoon, everyone, and welcome to Iowa Ideas In-Depth Week. This year is our 9th year of Iowa Ideas, an event that explores topics that are important to Iowans. This is probably one of the most important topics, and so we're excited for an important week of discussions about cancer in Iowa. I want to just quickly give a special thank you to our presenting sponsor, ITC Midwest, and our In-Depth Week sponsor, Unity Point Health in Cedar Rapids, for their support of the event. Their sponsor support makes the Iowa Ideas discussions available for free for everyone, and so that's an important thing. For those that are participating today, at the bottom of the screen, you're able to submit questions to the panel in entering them in the Q&A box, and those will be sent over to us, and we'll work them into the conversation. I'm the executive editor at the Gazette, Zack Kucharski, and I want to welcome, we have an esteemed panel of folks here joining us today, and I wanted to introduce each, and I'll just work away around my screen and then toss it to you guys for a little bit more in terms of introductions. We have Representative Austin Baeth, who's also a doctor with Unity Point in Des Moines, Dr. Richard Demming, who's with Mercy One Cancer Center in Des Moines and is the medical director of a facility bearing his name. And then we have Sarah Nash, who is with the University of Iowa and the Iowa Cancer Registry, where she's also an assistant professor in epidemiology. And so thank you to each. And I will, in that order, kind of, if you want to give a little bit more in terms of information about you and the perspective that you're bringing to today's conversation. And Representative Baeth, we'll start with you.
Thanks, Zach. Hi, everyone. I'm Austin Baeth. I'm a state representative representing the west side and south side neighborhoods of Des Moines in the Iowa legislature, in the Iowa House. I'm serving my second term, so this is my third year in the Iowa House. My day job, though, my chosen profession is as a physician. I'm an internal medicine physician with a primary care clinic, and I also work in palliative care. And this is a profession of medicine in which we work with folks who are oftentimes near the end of life. And in that role, I spend a lot of time with patients who are struggling with cancer. And so these worlds have collided for me, especially in the last couple of years, as we've learned about this cancer crisis that Iowa is going through. And so I've really been devoting a lot of my attention to finding state policy solutions to try to figure out the causes of our cancer crisis and to then start lowering those cancer rates.
All right, Dr. Demming.
Hi, I'm Dick Demming. I'm medical director of Mercy One Cancer Center here in Des Moines, Iowa. I'm a radiation oncologist by training, and I've been here at Mercy for 35 and a half years. So most of the time has been as a radiation oncologist, actively treating cancer patients, involved in the endeavor of killing cancer cells. But taking care of patients and their families is much bigger and broader than just killing cancer cells. So I'm involved in everything to do with prevention of cancer, screening, early detection, everything related to treatment, and then also follow-up care. One of my particular areas of expertise is survivorship care. So we have, with the high incidence of cancer that we have in Iowa and the very high cure rate, we're having more and more cancer survivors. Not every cancer survivor is cured of their cancer, but even those who are cured still may have lingering physical, psychosocial, emotional, financial, philosophical, spiritual issues related to their cancer treatment. So cancer survivorship has become a particular area of interest to me. I'm also the principal investigator for a National Cancer Institute grant that we have. 85% of cancer patients in Iowa get their cancer treatment at a community cancer center. The old way of doing research was that the research was only done at the university. We now know that in order to get enough patients in clinical trials and to get them through more quickly, much of the cancer research is done in community cancer centers such as our own. I also have served as the national board chair for the American Cancer Society Cancer Action Network. That is the advocacy and lobbying arm of the American Cancer Society, and has, as Representative Baeth has pointed out, public policy plays a very important role in helping to, number one, fund research to figure out what's causing the cancer, but number two, to invest in public policy that allows everyone the greatest ability to access prevention, early detection and treatment, and that's a really important role. As a cancer doctor, I can take care of cancer patients one at a time, but as somebody who is an advocate and lobbying, with the right bills, we can actually affect millions. And so I believe that we take care of cancer patients one at a time, but we also get involved in research and in advocacy.
All right, thank you. Sarah.
Thank you for the invitation to be here today. So my name is Sarah. I have many different roles, but one of my main roles that I'm bringing here today, one of the hats that I'm wearing today, is I'm the Director of Research for the Iowa Cancer Registry. So the Iowa Cancer Registry, we are the folks who really collect, we are designated cancer data collection agents for the state of Iowa. So cancer is what we call a reportable disease, which means through federal and state law, it is folks such as Dr. Baeth and Dr. Demming and the folks that they work with at their hospitals send us information at the Iowa Cancer Registry so we can really tell you what is going on in terms of the landscape of cancer in Iowa. So we're the folks who collect the data on the cancers that are diagnosed in Iowa, how they're treated, and how long somebody lives past their cancer diagnosis. We also do a lot in terms of data dissemination and data sharing. That's things such as this panel today, as well as one of the big efforts that we have going on right now is called the 99 Counties Project, where we're really going into each one of Iowa's 99 counties to share local county level data, to talk with folks, to hear their concerns. And then again, I think it's all tying back to policy today. We talk with them about things that they can do, that you can do, the listeners today can do to really address Iowa's high cancer rates at the community level, at the policy level, and at the individual level. So I'll leave it there.
Well, and maybe it's kind of a kickoff question. And first, thank you all for joining. But, you know, as we sit here today, I think most folks are aware that Iowa has the second highest age-adjusted rate of cancers in the U.S. and the fastest growing rate of new cancers. And so I'm curious, you know, as we sit here today, what has your attention? What do you think is the most urgent? But also, what do you think is going well or maybe needs a little bit more attention? I'd be interested in each of your perspectives on this.
Sarah, do you want to maybe lead off, you know, as the keeper of the data and
Sure.
the report that has just come out, and I'm sure Sarah is the lead author of Cancer in Iowa 2025, and maybe highlight what you at the Cancer Registry have pointed out as some of the key takeaways when you analyze the data for 2025. And then
absolutely, I'd be happy to start with that, and then actually that would tie nicely into Drs. Demming and Baeth can really talk about kind of the other side of it, the policy and the clinical care. So there's a couple of different things to say about the data in terms of what we're seeing. The first thing is that there really are 4 cancers that are driving Iowa's kind of uniquely high rates. Those are prostate, breast, lung, and melanoma. So one of the things that I think we're doing really well, and this is a little self-serving, but I think we do a great job collecting the data. We do a great job telling the story, and we're trying to do the best job that we can, really digging into it to try and understand what is going on in terms of the cancer burden in Iowa and why our rates are so high. So those are the four. When we take those 4 cancer rates out of the picture, our rates look very much more similar to the rest of the nation. So those are really the 4 that we're putting our attention towards in terms of trying to figure out, A, what is causing those cancers in Iowa, and B, what we can do about them. And I know that our other panelists will talk a little bit about what they're doing in that space. And then also Dr. Demming raised the Cancer in Iowa 2025 report. And he's already talked a little bit about survivorship. This is one of the things that we're really focusing on this year at the Iowa Cancer Registry and also at the Holden Comprehensive Cancer Center, whose community outreach and engagement team I work with. Because as Dr. Demming said, as our incidence is going up and our mortality is going down, that leaves us with an ever-increasing number of cancer survivors. And over time, our number of cancer survivors continues to increase. We estimate that there are about 172,000 cancer survivors right now in Iowa. And like our other panelists have said, these folks require specialist care. They have needs ranging from financial, psychosocial, physical, clinical, all these different types of needs. And so that's one of the things that we've been really trying to highlight this year, is how we as Iowans can work together to really increase the services that are available to folks.
So this is Dick. The statistics are irrefutable that Iowa is number 2 in terms of incidence, and it's also irrefutable that we're continuing to go up. So there is a great deal of concern about what is causing it. So when you look at all of the modifiable risk factors, and that's a term we use for things that we do that can influence what causes cancer, and you look at how we compare to other states, and those are things like smoking, physical activity, obesity, what we eat, how many calories we eat, how much alcohol we drink, radon, sun exposure, vaccinations for HPV. You look at all of those, and we do, on some of those are a bit higher than other states, and some were a bit lower. But I would say that the cause of the cancer is clearly multifactorial, lots of different things, and they can interact. When you look at Iowa as a state, there's 2 things that stand out that make Iowa different than surrounding states. And those are 2 things that I think need to have a deeper dive. And those 2 things are, number 1, radon, the way that the geology of the earth was created. We are sitting on more radon than almost any other state, probably more than any other state. We know that radon causes lung cancer, but radon probably also contributes to other cancers. So I think radon needs to be looked at even more deeply than we had in the past. And then second would be the environmental exposure to chemicals. And these can be chemicals like PFAS and plastics, but it can also be the chemicals that we get exposed to through agriculture. We are blessed with just immensely fertile land, and much of that is under cultivation, and much of the cultivation includes using ag chemicals. And when you look at the tons of ag chemicals per square inch, Iowa ranks number 1. And looking at what that has, the consequences that may have. It took decades for us to correlate cigarette smoking with lung cancer. It's not unusual that with thousands of chemicals that we're exposed to, causing dozens of different cancers, that it's difficult to come up with this exact cause and effect. But many of us believe that we need to do a deeper dive into what the chemical exposure that we are all experiencing through the air and water as the chemicals distribute through Iowa, what effect that might have on us and our high incidence of cancer.
And with all of this happening in the background, we want to talk here about what's going well, what isn't going well. what hasn't been going well. This is the third year in a row we've had a report come out saying that Iowa has the second highest cancer rate in the nation. First report was in 2023, February. My job has been trying to get my colleagues in the Iowa legislature to prioritize this. This year, this legislative session, there's been over 2,000 bills introduced. And of the cancer bills, of which I've been maybe one of the only few people writing them and helping to assist write them, we've had 4 pass out of one chamber, 0, and that's the Iowa House, and 0 go through the Iowa Senate. And so my biggest frustration is to try to urge my colleagues to start prioritizing this above some of the other things that we're doing, because these are lives. These are human lives that are hanging in the balance. And cancer is something that doesn't care if you're a Democrat or Republican, doesn't care how old or young you are. Cancer does not discriminate. It threatens everyone. And so while it's very unfortunate to have a unifying issue like this, fighting cancer should be an issue that fosters bipartisanship, that fosters unity in a time of political divisions. And I will say that looking at the glass half full, we have had 4 bills now go through the Iowa House, which is 4 more than we had 2 years ago. And so we are slowly starting to make progress. And we're having to first identify some, I think, mostly apolitical, nonpartisan issues like fighting radon as some of the low-hanging fruit before we can tackle some of the, I think, more politically difficult issues, which would be reducing exposure to agricultural chemicals, seeing the influence that the agricultural industry has on Iowa politics.
I was wondering if you could speak a little bit more of, starting, with radon, how much of the work of advocacy is also starting with an education campaign? Because I would imagine, I think radon has always been one of those topics where some folks, have a deep understanding of it, and others, if they've didn't grow up here, maybe never even heard of it. How do you approach, building this so that you can be effective on the policy front?
Right. I think there are a lot of things here that could be done without any politician, which is, if we had a robust public education campaign that could be done through the Department of Health and Human Services. Now, they would need the money typically allocated from the legislature to do that, but they could always shift money around if they wanted to further bolster this. Certainly, there have been nonprofit groups that have assisted with this education. And just to perhaps for our audience to provide a little bit of that education here, Iowa is one of 2 states in the country in which every single county has a zone 1 risk for radon exposure. That's the highest level risk of radon exposure. It's Iowa and North Dakota. And it's because of the way that glaciers moved this type of radioactive soil into our state, it's unavoidable. And because of that, it's estimated that approximately 70% of Iowa homes have an elevated radon level, 70%. Yet only 1 in 15 homes have been checked for radon in the last decade. So, first you got to identify the problem before you can even work on fixing it. And so getting the word out that folks are at risk of exposure to radon, the importance of that risk, the fact that radon is the number 1 cause of lung cancer in non-smokers, the second leading cause in lung cancer of all folks. And we identified lung cancer being one of the main types of cancers that's elevating Iowa's overall cancer rate. So public education is important. And then having the public educate their lawmakers saying, hey, protecting me from cancer is important. Radon is something that you could throw your support behind of helping mitigate. I think that's the other important piece of this. And a 3 to 4 sentence email to your state representative and state senator can go a long way Because as I said, if we have 2,000 bills that are pulling our attention every which way, it's the loudest bills that end up getting passed. And so folks who really communicate to their lawmakers that fighting cancer is important to them are the ones that are going to be able to bring this priority to the top.
And talking about prevention, so it's always better to prevent cancers than to treat them. And so I mentioned the whole list of modifiable risk factors. One of the other things that everyone needs to know is that access to healthcare is fundamental to be able to prevent cancers and do screening and early detection. So we have to continue to make sure that we're dealing with access to healthcare. And Medicaid is one of the forms of insurance that individuals get that help them get the screening for cancer and help get cancer treatment. When the Affordable Care was passed, the goal was to get everyone to be able to have health insurance, and the expansion of Medicaid was a necessary part to make sure that those with low incomes who might not be able to afford to buy the insurance over the marketplace have access to health care. Once you have access to healthcare, you can then do screening for cancer. Screening is finding a cancer at an early stage when it is curable. If you don't have access to healthcare, you don't have access to screening. And studies have shown time and again that cancers are found at a later stage where the cure rate is much worse and that they fare much worse. So right now, there is a proposal to put work requirements in for individuals with Medicaid. If you've got active cancer under treatment, you're exempt, but once a month, you have to prove that you still have cancer and that you're still exempt. So we're very concerned that some of the legislation that's going to modify Medicaid is going to interfere with the accessibility of having health insurance, and that will result in a higher death rate. The other thing I would point out is that we need to continue to educate individuals about screening. We've done a good job with mammography, but that's been decades. So right now in the state of Iowa, almost 80% of women eligible for mammograms are getting mammograms. But the cancer that causes the most death is lung cancer. And we actually have a screening test for lung cancer. It's a low-dose CT scan for individuals who are smokers or have a history of smoking, but we only have about 20% of eligible individuals that are getting that screening done. That would save lives. So 2 points. One, accessibility is an important issue, and Medicaid is part of that. And number two, we need to continue to educate individuals on screening for cancer, and that includes screening for lung cancer, which is the cancer in Iowa that causes the most deaths.
And I just wanted to add to that, Dick. I think those are really good points. And again, just to plug the Iowa 99 Counties project. So we are coming around to all 99 counties, and all of this information is information that we share with folks on a local level. So we have information about who you can contact to get radon testing in your area. We have information about the prevalence of certain modifiable risk factors in your area. We have information on the stage at which people are diagnosed in your area. And so all of that really, I think we need to think both statewide and locally as we're trying to work together to address this problem. And so I would encourage folks, we have a website, iowacancerregistry.org/99, that folks can go to. If we've been to your county already, the slides will be there with all of that information. We have a really nice resource guide. You can see if we're coming to your county. As soon as I get off this call, I am driving up to Waterloo to go to Black Hawk County. We'll be at Black Hawk County later on today. And then the ones that we still have left to schedule. So happy to share more information about that, or I think that a lot of these things that we're talking about are being kind of brought into that project. So I just wanted to say that if folks want to learn more, that would be a great place to do that.
Sarah, maybe you could just talk a little bit more about the reaction as you're doing this. What are you seeing? Are folks aware of kind of the picture within their county? What is the reaction that you're seeing?
I think it's really interesting. I think the folks on this call, as well as all of our partners across the state, have done a really good job raising awareness about Iowa's second highest cancer rate as a state. I feel like when we're going out and doing these presentations, folks know that we have high cancer rates. I think I was somewhere the other day in an elevator or something, and somebody was talking about it, and I just kind of smiled and looked down at my phone and thought, well, that's nice. I'm glad that people are talking about it. So I think we're doing a really good job kind of getting folks to know that we have high cancer rates. I think the thing where I really think this project is wonderful, and where I think the work that Drs. Baeth and Demming and others are really doing a great job is trying to go that step further, right? To share that county level data, to make sure people know what risk factors are modifiable, what we can do as individuals, what we can do as communities, and how we can support our policymakers to pass those policies at a state level that will really help bring our rate down. I can't remember which one of our panelists said this, but this cancer takes a long time to develop, right? A really long time, 10 to 20 years. And so the rates that we are seeing today have been, we've been coming the train has been driving down this track for 20 or so years. And it's going to take a long time and a lot of effort and a lot of investment from all Iowans, from the single person to the state level policies, to really turn the ship around. I'm all about the transportation metaphors today, I guess. So I think that's one of the things that I think that folks have not maybe thought about as much, is that how we are going to all have to work together to address this issue.
I wanted to ask also, we've talked about the insurance side of things, but there's also been a lot of concern about the research and whether it's reductions in funding through some of the federal funding sources, or the reduction in the number of people in some of the federal agencies. How concerned are you about the continuity of research? What impact is it having at this point, and what do you see as the potential impacts?
So I'm very, very, very concerned. When you look at the proposed budget at the federal level, it's to cut NIH by 40%. I mean, that's going to have a devastating impact on research. The NIH funds more research than any other body. And if we cut research by 40%, it'll have a huge impact, and it will have an impact that will last for decades, as researchers that are in the field of cancer research are going to go elsewhere if they have no funding, and they'll probably go to other countries that might still have funding, or individuals that are on a path to get a PhD and go into research will go an alternate path. So very, very concerned. We're seeing some changes already. We've had some clinical trials that have been closed. We've had some reduction in staffing, but the uncertainty of not knowing whether what you're working on is going to be funded even in the next quarter is having a real devastating impact.
I just wanted to piggyback on that to say that I think one of the places where we as public health practitioners have not been super great at communicating is the importance of government-funded research. And I think that the reason why it is so important that we have this funding is to make sure that our science is objective. The government is one of the few places where we can ensure that when the science is done, that they give the money to the researchers. And by the way, it's not a free handout. It's very, very difficult to get NIH funding. About less than 10%-ish of grants that get submitted actually get funded, and they go through a very strict double layer peer review process, first by peer scientists like myself who sit on review panels, and then it goes to the institute like the National Cancer Institute or the National Heart, Lung and Blood Institute, whoever's funding it, to then go through another layer of scientific review and approval. And so I think that the importance of this process, one, ensures that only the best science is being done, and two, ensures that the science is both rigorous and is objective and is not interfered upon by the funder. And so I think that that's something that we could probably do a little bit better job of communicating to folks to really understand why it is important that we continue to do this funding that Dr. Demming is talking about.
And when you say not interfered by the funder, that comes from like pharmaceutical companies or others who may have a stake in the outcome, correct?
Yes, and I will say that that's not to say that all funding or that all research that is funded by a pharmaceutical company or somebody else is necessarily unobjective. That is just to say with government funding, we know that it is objective, 100% sure that it is, because the government does not have a say in the research funding that is, the research that is published out of that funding.
Dr. Baeth, I wanted to follow up kind of on you talked about low-hanging fruit and the 4 bills that had advanced out of the House. And I think one of those bills related to the use of tanning beds for those under 18. And I think it was the first time the Senate had taken it up previously, but then hasn't done it this time. I'm just curious, what is the feedback that you're getting about why some of these things aren't getting more discussion at the State House?
Let me give a little background first. So indoor tanning using a UV tanning device, these indoor tanning beds. The World Health Organization says that indoor tanning is a class 1 carcinogen. It is the highest risk carcinogen that we know. So basically the evidence is solid that indoor tanning causes cancer, especially melanoma, and melanoma, if not caught early, is oftentimes fatal. It's a deadly form of skin cancer. We also know that exposure to UV radiation is most dangerous when it happens at young age. So a lot of the melanoma that we see happens from sunburns that happen in childhood or in adolescence or teens or early adulthood. So because of this, many countries and 44 states, not Iowa, have restrictions on the use of indoor tanning beds by minors, by kids 18 or under, or in a few states, 16 or under. And the whole thought behind this is that, you know, if we expect a person to have to be 21 to drink alcohol, to have to be 21 now to buy cigarettes, we expect somebody to have the maturity of adulthood in order to make a potentially dangerous decision. Well, in the state of Iowa, as it currently stands, a 13-year-old could ride their bike to the indoor tanning salon and get a tan. That is completely legal. And so we originally proposed a bill that actually be an outright ban on minors in Iowa using an indoor tanning bed. That made it through subcommittee in the Iowa House. When it got to the full Republican side of the Iowa House, they were uncomfortable with that because I'm a Democrat. I can't exactly go inside their heads and tell you why, but I heard a lot of the response was, well, because of freedom. If I want to be able to get a tan, or if my kid wants to be able to get a tan, they should be able to. I won't go into that, but that in general has been the overall opposition to having restrictions in Iowa of minors using tanning beds, is that, well, this is a free country. If we know the risks, we should let our kid get a tan. I will note that there's some studies saying your chance of getting melanoma are many times higher, like multitudes higher, if you tan at young age. And it became a watered down version in the Iowa House where instead of banning 18-year-olds and below from getting a tan, below 18 from getting a tan, now it is just parental permission if you're below 18 to get a suntan. That passed the Iowa House and has not really gotten a day in court on the Senate side. And at this point in the legislative session, likely will not. Why? I can't tell you if it's more because, again, more of that sort of I guess, pro-freedom take on that, or if it's just because, again, there are 2,000 bills proposed this legislative session and their priorities are elsewhere.
Can I just jump in and say why that's so important? Because I know that we talked about, Dr. Baeth, I think you did a great job of saying why that's so important. And I wanted to add that melanoma is our 5th most common cancer in Iowa. And it is one of those 5 cancers, 4 of those are really driving our high rates. Melanoma, breast, prostate, and lung. And then the 5th one is colorectal, which is a high burden in Iowa, but is not driving our uniquely high rates. So just to add to what Dr. Baeth is saying, is that this is super important in Iowa specifically because it is a high burden cancer that is driving our uniquely high rates.
I also wanted to kind of talk about when you look at some of the data, Sarah, of the incidence of cancer. You see, if you looked county by county, you see it's different types of cancer. Breast cancer is more common in the city. I think skin cancer, if you look at the northern tier of counties in Iowa, there's a much higher rate of that. What is that data telling you? Does it say anything in terms of cause? Does that start to get into the ideas of what research needs to be done going forward?
That's a really great question. One of the reasons I love working at the registry is because I feel like it is what we call great for hypothesis generation, which means it doesn't necessarily tell us the why, it tells us the what. But when we dig into the what, it can kind of give us some clues to the why. So we need the researchers. We work with folks at the Iowa Cancer Registry who are interested in all of these things. We share our data, and we work with researchers who are interested in melanoma, who are interested in agricultural health, who are interested in water quality, all of these things, to try and understand these kind of regional patterns of cancer. And you're absolutely right. Breast cancer is found more commonly in the urban areas. Now, one of the hypotheses, again, we have to then show this, but one of the things that we know from others' research is that breast cancer is strongly linked with education. The reason for this is that women who are more highly educated tend to delay having children, and that is a biological risk factor for breast cancer. So, and women who are more highly educated tend to cluster in the urban areas. So that's a long train to causality, but that could be one thing that is contributing. Like you said, we know that lung cancer is higher in the more southern part of the state, like lower 3 tiers. We also know that smoking prevalence is very high in those lower 3 tiers. Like we've talked about, radon is very high all over the state and is a concern for everybody in Iowa. Melanoma tends to be higher in the top 3 layers of counties. I am really curious about that. I know we've got a lot of farmers up there in northern Iowa, but we have a lot of farmers everywhere. We have a lot of folks, and Dr. Baeth talked a lot about how melanoma is linked to UV exposure, to sun exposure. And then the 4th cancer that's really driving our high rates is prostate cancer, and that tends to be higher in the west and particularly in the northwest of Iowa. Now we have some theories. Again, we need to look at the data and figure out if this is true. But prostate cancer, we have a theory that this might be related in part to differences in screening, and folks in the western side of the state might be screening differently to folks elsewhere in the state. Again, that's just a theory. We have yet to test it, but we're working on it right now. Does that answer your question?
Yes. And this summer, I believe the university is involved in kind of bringing folks together to kind of develop a research plan. That may be outside of your area, but...
No, I'm actually very involved in this as well. So we have what we are calling, I'm not quite sure what we're calling it anymore. It was a blue ribbon panel. Now I think it might be a gold ribbon panel, but we have a panel of experts who are internationally and nationally renowned. So these are folks from outside of Iowa who we have asked, who have expertise in those 4 cancers that we talked about, breast, prostate, lung, and colorectal, melanoma. And then we have asked folks who have expertise in the common known risk factors for these things to have all come together. So I can't remember how many we have, but it's somewhere between 10 and 15 folks who are international and nationally renowned experts on these topics, to come together they're going to do a few things. We're going to talk to them about the data that we have from the registry and elsewhere. Then they're going to kind of go away and think about what these data means for their area of expertise. And then they're going to come back and talk to us and talk to each other about what their recommendations are in terms of what research we should be doing. And then we are going to use those recommendations to really put together a research agenda. And I would hope that might turn into things like a policy agenda that we can really start to think about what research needs to be done, what policies might we really support, those kinds of things to reduce our burden of cancer.
Okay. Dr. Demming, you talked early on in this about the survivorship and the kind of the needs of patients as they live through. Why is this such an important piece of care, and what does that look like in terms of you're maybe through treatment, but
Right.
why is that an important piece?
Well, it's important because of the number of cancer survivors. So in the United States, there's about 20 million cancer survivors, and we're probably close to 170,000 cancer survivors in the state of Iowa. So lots of individuals are cancer survivors. The care system that we have generally focuses intently on treatment of cancer and on killing cancer cells. So lots of time, effort, and money is spent on diagnosing and treating cancer with surgery, radiation, chemotherapy, immunotherapy, hormone therapy. And there isn't the same degree of time and attention and money spent on taking care of individuals after they've come off the cancer treatment conveyor belt. And we don't say this, but the way we treat this, it's almost like we've cured your cancer, you should just be grateful. Many, many individuals have lifelong issues related to physical, psychosocial, emotional, sexual, financial, philosophical, spiritual issues. I mean, cancer care is the number one cause of personal bankruptcy in the United States. So, and many of the treatments that we provide patients, surgery, chemotherapy, radiation therapy, have late lingering issues that can affect employment, certainly can affect function, can affect quality of life. And we haven't systematically done a good job of addressing those issues. So at this point in my career, part of what I'm doing is creating a cancer survivorship program that specifically addresses all of the issues that cancer patients and survivors may face. Yes, we need to do surveillance for the cancer they were treated for. Yes, we need to do surveillance for other cancers they might be at risk for. Yes, we need to educate them on how to mitigate the risk factors so they don't get other cancers. But we also need to address all of the lingering side effect issues that are affecting their quality of life. So in my cancer center, we have a survivorship program, and we brought into the program not only expertise on the issues that cancer survivors face, but we have created an integrative oncology program that brings into the cancer center things like acupuncture, massage therapy, chiropractic, osteopathic manipulation, Reiki, reflexology, physical therapy, mental health counseling for patients, mental health counseling for family members, social work, financial aid counseling, sexual health counseling, music therapy, art therapy, support groups. And this hasn't routinely been the case, that all of these integrated services are available for individuals going through cancer or that are facing survivorship. So the sheer number of cancer survivors we have in the United States and in Iowa really demands that we do a better job for addressing their ongoing needs.
Now, just correct me if I'm wrong, but that's not covered by insurance at this point. So a lot of that is philanthropy. Is there,
that is correct, that part of getting things covered by research is to continue, part of the difficulty with getting things covered by insurance is we need to not only, as we provide these services, but continue to generate the evidence showing the benefit. And you're right, the 20 things I just mentioned, most of those are not covered by insurance. So right now we're covering them by philanthropy. I know that there's some politicians, not Representative Baeth, who believe that, yes, we should just have philanthropy come in and take care of all of the problems and save the government a budget. But I believe firmly that there are essential services that are best served by the government. Education, public education is one of those. And I think healthcare is right up there as well. That the government is better suited than others to provide systematically a way of uniformly providing certain services. And when you look at those democratic countries in Northern Europe that are democracies but have a great deal of social care involved, they have the best results in terms of preventing cancers that are preventable, screening, and get the best outcomes in terms of health consequences, including maternal mortality and even life expectancy. So we don't do a really good job with public health in general with our patchwork way of paying for health care.
Okay, I appreciate your thoughts there, and I also wanted to ask just do you see studies? Is there some kind of a link to maybe start to change the ball there, where you're starting to look at those outcomes to patients? Are some of these clinical studies that you're involved in really just on the treatment side? Is there a field kind of emerging for those outcomes?
There is. And the NCI clinical trials that we do, most people are familiar with the treatment clinical trials where a person has a certain type of cancer, a certain stage, and they get either treatment A or treatment B, and it's a randomized study. But we are also doing clinical trials on symptom management, clinical trials on cancer care delivery. I just enrolled a patient in a clinical trial today who has profound fatigue as an ongoing side effect of their cancer treatment. And we actually have a randomized prospective study looking at a medication that may be beneficial. So you're right that the old-fashioned cancer research was kind of just focusing on treatment of cancer. Now I'm happy to say that there's a broader perspective of trials looking at prevention, screening, early detection, treatment, but also symptom management and survivorship.
And do you see? So we have the cancer report each year, and it has kind of the information from each case. Do you see expanding to collect more of some of these factors or the environmental factors going forward, Sarah?
That's a great question. I would love for the answer to be yes, but I don't think that will be within our remit. And let me tell you why. We have a very specific set of things that we collect. So the cancer surveillance system across the US, the cancer registry system, is governed by very specific standards that come from the American College of Surgeons, from the National Cancer Institute, and from the Centers for Disease Control and Prevention. And we follow those standards, and we collect the data items that we are bound to collect by our funders and by those standards. So our funder is the National Cancer Institute here in Iowa, and so they say, we would like you to collect these data per the standards of these standard-setting organizations. Now, it takes a lot of work to collect those cancer data, and I like to think, and I do think, that we do it very well. The reason we do it very well is because we are the specialists. We are the experts in collecting these data. It is very difficult to collect lots of different types of data. Environmental data, for example, are a huge challenge. And so when I say, no, we are not going to collect those data, I don't mean those data are not important to collect. I mean, I think you want the experts in collecting that type of data to collect those data, right? You want the experts in environmental health. You want the experts in water quality. And there are people, for example, the Center for Health Effects of Environmental Contaminants here at the University of Iowa, who are the experts in collecting those types of data. So while we probably will never collect those types of data because we are not the experts in collecting those types of data, we do work with folks who are the experts, and we share our data, and we try and bring all of these different data sources together to really understand the issue. So I think when I say no, I don't mean this is unimportant. I mean, we work with the people who are the experts in doing all of these different kinds of things so that we can be the experts in collecting the cancer information.
I wanted to kind of, for everybody, this is a question, but if you had, your 3 policy picks, what would be on your menu of things that you would like to see addressed? Whether it's, the most impactful, or you think that it could lay a foundation. What would you pick?
So this is Dick. Access to healthcare is, I think, number one. If we don't have access to healthcare, we can't really accomplish the rest. So I'll just throw that as number one. I've got a 2 and 3, but I'll pass it on to Austin and Sarah.
I'm going to see if I can guess Dr. Demming's next one, and it's going to be raising the tax rate on cigarettes.
That was my number one.
Okay.
So at least you got me if you didn't.
Cigarette taxes are one of the most effective public health policies that we have to reduce smoking rates. And, you just heard a lot of speculation about, what are the various X factors that are causing Iowa's elevated cancer rates. Well, all of those X factors combined probably still aren't going to match how much cigarettes cause cancer in the state of Iowa. And so even though we might smoke just about as much as the average American here in Iowa, if we can drive that smoking rate down, that is going to be the biggest bang for the buck, literally, because we got to raise our cigarette taxes by approximately $1 at a minimum, if not $1.50 per pack, if we're going to see appreciable reduction in our smoking rates. We know that especially teens are most price sensitive. And so when you increase taxes on cigarettes, we see teen smoking rates go down. So that's going to be my number one, and my number 2 right along with that. In the state of Iowa, we're in a minority of states here, we don't tax e-cigarettes. We don't tax vaping. And I'll tell you why. It's because the lobby. It's because there are some very powerful e-cigarette lobby. And you go into any high school these days, they aren't smoking Marlboros. They're puffing on bubblegum flavored Juuls or whatever. E-cigarettes it's been now well found in literature, e-cigarettes, vaping is the gateway to smoking cigarettes long-term as an adult. I think 1 in 4 Iowa 11th graders vape. We need to start taxing it here on parity with cigarettes, and finally we'll start to see smoking go down, hopefully, here on out.
Oh boy, you guys got the heavy hitters. Those would probably have been my top. But I think if I could add one, actually I'll add 2 to these. These are on topics that we have already talked about. The first, Representative Baeth talked about this already. The tanning bill, banning tanning among minors, that would be on my list. As well as, I think we've already talked a lot about radon, and that I think that there are still things that since you guys took my top 3, I'm trying to be creative and say I think that I would also probably add something around radon. So for example, right now, if you work with your local public health department, you can get low-cost radon testing. But mitigation can be expensive, right? If you find that you have an issue with radon in your home, so the issue with radon is if it gets trapped like in a basement, if you have a crack in your foundation or a hole where a pipe is, and it gets trapped in your basement, then that is what can be super harmful. And mitigation, if you find that you have high levels of radon in your home, mitigation can be relatively expensive, especially for those low-income folks. And the other thing that I don't believe, and Representative Baeth can correct me if I'm wrong on this, but I don't believe that we have any laws that say that landlords need to test. Right now, I think the only time that one has to test is when one is selling a house. I don't believe that there's anything on the books that says that landlords have to test or mitigate for any rental properties. And that is something that I would I don't know if that ever stands a chance of passing, but that's another thing that I would, if I'm having to be creative and go past the top three that Representative Baeth and Dr. Demming have mentioned, I would probably add those to the pile.
Yeah, so Sarah, you're correct. Right now, there really is no laws concerning landlords or rental properties in terms of radon. That is a bill that we have winding its way through the legislature. I don't know its fate for this year, but this would, at the very least, give tenants an out. If they find their unit has an elevated radon level and their landlord fails to mitigate it, they would be able to break their lease without a financial penalty. So that is one bill that we're working on to get a start. There's another bill we're working on. Sarah, going to your point of radon mitigation, it's expensive. It can cost up to $2,000 to mitigate your home if you're found to have an elevated radon level. So one bill that looks like it has momentum behind it, we passed it through Ways and Means in the Iowa House, is to give a $1,000 tax credit for radon mitigation. And so that's something that I hope that might become law this year, actually. Another bill is for new home builds, because we said, all of our soil has radon in it, that when you're buying a new home, building a new home, this would require home builders to incorporate passive radon mitigation to try to help make that home radon proof to begin with, so we can start to reduce how much of our housing stock has elevated radon levels in it. And then there was a question of, how do I get my radon tested? There is yet another bill that is working through our budget right now, that if this becomes law this year, Iowa will be offering free radon tests to any Iowa homeowner or renter who asks for it. We're going to be appropriating money for free radon tests. This is something North Dakota does. That's that other state that has elevated radon levels throughout the state. That's what we need to do here in Iowa. And if you don't want to wait for that, you can go online. You can get a radon test sent to your home by mail. It can cost $15. I often use Alpha Energy Labs, aelabs.com, I believe it is, Alpha Energy Laboratories. They can send you a test through the mail to your home. You open the packet, follow the instructions, send it back in the mail, and they'll let you know if you have an issue or not. I
promise that you did not set me up for that, Representative Baeth. I had no idea that those policies are in the works, but I'm super excited about what you just shared.
Again, we're going after low-hanging fruit here, and finally we got some momentum around radon, so we're going to run with it.
We just got a bunch of questions passed through to us, but one of the other ones that I wanted to at least ask about is, what about glyphosate exposure? And that's identified as a carcinogen in Europe. Why not here in Iowa? And I, not sure who wants to take that one first.
Yeah. Do we have another 3 hours? Because
I would say one reason is the amount of money that the ag companies are spending in politics is making it difficult for legislative action. So right now, up at the State House and Austin, you can tell us where we're at. I think it hasn't gone through the House, but there was a bill that was to grant immunity from future lawsuits. So to give blanket immunity to by the company that makes Roundup. So there's no doubt that it does provide tremendous benefit in terms of killing weeds, and it does enhance production. But, just like chemotherapy can cause cancer, radiation can cause cancer, there's lots of these chemicals that cause cancer. They also have some economic benefits. So then if we don't have independent research that looks independently without looking at the return on investment of a product, then you end up with individuals that move forward with the financial rewards outweighing health concerns.
All right. Well, we didn't have 3 hours to go with that question. We had about 3 minutes. And so I think, that puts us at a place where we have to stop. Obviously, there's a lot working in this space. There's a lot going on, and there are a series of conversations. And just to run through the remainder of the week, tomorrow's session looks at cause and effect, what makes Iowans susceptible to cancer, what is known and what's unknown is the conversation there. Pediatric cancer is the topic of Wednesday. Thursday is the economic impact of cancer. And Friday's advancements in screening. We had a lot of conversation around screening today, as well as the treatment. And so that topic comes up on Friday. And so for everyone, I want to say thank you to all of the panel. I know there's lots of ways you can spend your time, and you're experts in the field. And so I appreciate you taking time with us today. And for our attendees, I appreciate you taking time as well. Have a great day.